Motion preservation spine surgery is actually not that new. It's a concept that's been around for decades in Europe. We have some of the best clinical trial data available even in the United States. The idea is our spines are these biomechanical wonders. There are many, many, many different moving parts, and there are actually 96 different joints, and if you count actually all the joints that even attached to the spine, about 139 of them. It is extremely complex, and the idea in the past, especially from trauma, is that if there's instability in the spine that's potentially dangerous, you could become paralyzed or severely injured, and you need to stabilize. And the only way we have stabilized the spine in the past is to fuse, making one bone segment attached to another bone segment. Again, it works. It works very well, and this was then extrapolated to degenerative disease as we get older, as our bodies start to get more arthritic, things start to hurt. If we do certain manipulations to the spine to relieve that pain, sometimes it's similar. We need to stabilize it. And to stabilize it, or if there is abnormal motion that's causing pain, fusion again works. The problem is that not only has fusion become sort of the pejorative, it has some negative connotations out in the community because all of us have friends or parents or grandparents who've had fusions who then have to go back and get more surgery. The thought is that a fusion begets a fusion and begets a fusion. We actually have data to support this. In many cases, what happens is that when you fuse segments of the spine, again, an anatomic part of our body that is designed to be mobile, in motion, when we fuse segments, it creates unnatural stresses at adjacent segments. What does that mean? It means that levels above or below the area that we are immobilizing, we're fusing, are stressed because they're now dealing with a part of the spine that's no longer moving, and they're still moving. So motion preservation spine surgery is this idea where we can alleviate some symptoms, often pain, by replacing the pathology, something that's gone wrong, with a device that preserves motion, does the opposite of fusion. It gives your normal anatomy an opportunity to continue to work, thereby reducing the stresses on those adjacent segments. Yes, you have to be an excellent clinician. You have to look at things objectively. You want to come to an answer. But sometimes the answer is just being there for your patient, listening to what they want.